Good morning, everyone. Welcome to the Health Services Research Grand Rounds, hosted by the Health Services Research Center at the University Hospitals in Cleveland. This session is being recorded and will be available to view from the UH Research and Education Institute website. Please mute your microphones throughout the presentation. And if you require any technical assistance, please contact R&E team, Nicole Bollinger or Abigail Zona, who are on the call. And if you want to ask questions, you can type them in the chat. Please note that questions can be seen by all attendees, and you have the option to submit them anonymously if you prefer. Now, it's my pleasure to introduce my colleague and our inaugural Grand Round speaker, Dr. Goutham Rao. Dr. Rao is a graduate of McGill University School of Medicine in Montreal, Canada. He completed his residency at the University of Toronto and fellowship training at the University of Pittsburgh. He is currently the Jack H. Medley Professor and Chairman of the Department of Family Medicine and Community Health at University Hospitals and Case Western Reserve University School of Medicine. He also serves as Chief Clinician Experience Officer for the University Hospitals Health System. Dr. Rao is a board-certified physician in both family medicine and obesity medicine and practices in both fields. He is the principal investigator of the Agency for Healthcare Research and Quality, also known as ARC, funded UH Advanced Center, which stands for Advancing Diagnosis Through Validated Analytics and Novel Collaborations for Excellence. UH Advance is one of just 10 funded centers of its kind in the United States. Its mission is to identify best practices for diagnosis. Dr. Rao is an established health services researcher who has served as principal investigator for more than $8 million in grants from ARC, NIH, and PCORI. He is the author of well over 100 publications, including 6 books. Among this is The Rational Decision-Making, a Case-Based Approach, published by McGraw-Hill, a unique textbook that combines the disciplines of evidence-based medicine, clinical epidemiology, and biostatistics, and is used by medical students and others all over the world. Dr. Rao serves on a number of important national committees. He is a member of the U.S. Preventive Services Task Force and ARC's Health Information Technology Research Study Section. He is past chair of American Heart Association's Obesity Committee and has served on the National Quality Forum's Quality Measures and Child Health Steering Committee. And he also serves on several medical editorial roles. Among his major editorial roles, he serves as the editor-in-chief of Family Practice, one of the world's leading journals with an emphasis on primary care. We are very delighted to have you here and as our inaugural speaker for the Grand Rounds. Thanks, Dr. Rao.
Thank you, Sam, and thanks to all of you for joining us today. So I'm going to start by sharing my screen, and hopefully everything will work. Start slideshow. Okay. All right, looks like we are up and running. So thanks, Sam, once again for that kind introduction, and to Nicole and Abby and also you, Fritz, for helping to make this happen today. Extremely well organized as usual. So as Sam said, I am the PI for the UH Advanced Center, which is essentially devoted to identifying best practices for diagnosis. But I'd like to start with why that's important and how I came to this center personally, and to this area. So some of you are familiar with the idea of diagnostic error. There was a National Academies of Medicine report in 2015 that was influential, not quite as influential as To Err Is Human, the report that came out in 2000 about medical errors in general. But it found that about 5% of adults who seek outpatient care each experience a diagnostic error. Now we can argue about it. Is it really a diagnostic error? How are you debating it? These are debates that we've been having in the community that's interested in this for 20 years or so. But you know that post-mortem examination research spanning decades states that diagnostic errors contribute about 10% of patient deaths. And you can define a diagnostic error either as a misdiagnosis, in other words, the wrong diagnosis, a missed diagnosis, or a delayed diagnosis. And I always say anyone can make a diagnosis if you wait long enough and the patient gets sick enough, which you don't want that to happen, of course. So they are responsible for about 6 to 7%, 17% rather, of hospital adverse events. And not surprisingly, diagnostic errors are the leading type of paid medical malpractice claim. They are twice as likely to result in death compared to other claims, and they actually constitute about the bulk of payments overall. So extremely serious, and I think this is information that most people are already familiar with. So I got interested in improving diagnosis more than 20 years ago. And some of you are familiar with JAMA's series of papers entitled The Rational Clinical Examination. The idea behind this paper was that there is a rational, evidence-based way to make a diagnosis for common but challenging conditions. You think about, we hear stories about patients, for example, with multiple sclerosis. Why does it take a year or several years sometimes to come up with a diagnosis? Well, there's a lot of reasons, of course. The symptoms can be very vague to begin with. At the outset, and presentations can vary over time. It just makes it very hard to do that. So the goal of the Rational Clinical Exam Project was to develop guidance to approach common conditions, common but challenging illness conditions. You don't have to be an expert in the field to embark in the project, and I certainly was not in the field that I chose to pursue. This is back in 2002, 2003. So this is the paper I led. It's called "Does this patient have Parkinson's disease?" And essentially, it starts with a scenario, and then it talks about symptoms and signs that are most useful in making a diagnosis of Parkinson's disease, which you can imagine is a very challenging condition. Someone who presents with Parkinson's disease, typically older, will have vague symptoms, maybe nothing, maybe a tremor, maybe a shuffling gait, maybe some facial expressions that aren't typical, but it doesn't mean they have Parkinson's disease, and it does take some time. So these are the symptoms and signs that will lead you towards that diagnosis. So back in about 2010, 2011, a gentleman by the name of Paul Epner came to my office in Chicago, and he said, "I heard you contributed to this book. You're really big into this area. We just started a new society called the Society to Improve Diagnosis in Medicine. We'd love to have you involved." And I started to leaf through the book, and I said, Paul, I'm glad you want to have me involved, but I think I didn't say this was garbage, but my whole thinking around this has changed a lot in the last 10 years. And he was like perplexed. And he said, why? I think this is great. No, you cannot extract single symptoms and signs from individual studies, pool them together and say, this is the right approach to diagnosis. That doesn't make sense. If I know a patient has tremor, I'm going to ask additional questions that may relate to Parkinson's disease. So there's an interaction that is not accounted for when we start to extract likelihood ratios, odds ratios from individual studies. And I think we need a more cohesive, comprehensive approach to problems that is broad in scope and takes these subtleties into mind. And that's where we began to develop best practices. So, and the scientific approach to diagnosis, Sam alluded to rational medical decision-making, a textbook that came out in 2007. It's still widely used. It includes a chapter on the scientific approach to diagnosis. But one of the criticisms, and I accept this myself now, is that it's very analytical. It's like, yes, you ask this question, you'll get this, and then you move on. It's, an Bayesian approach to things. But that's really not how doctors think. We think very broadly, or we've already made up our minds. So there's many different approaches to it. So we have a need for new diagnostic tools, tests, and procedures, no question about it. The vast majority of research in the diagnostic area is, of course, molecular diagnosis, gene-based diagnosis, all kinds of assays and tests, because that's where the money is. But clinical diagnosis is still extremely important. Here's an excerpt from an essay by G.T. Levitt from the University of Southampton. It's about 36 years old. But what he wrote is really important. It says, in medical school, we spend a vast majority of our time learning about differentiated illness. And I'm assuming at least some of the folks on the call today went to medical school. And you may have had the same experience that I did. at the Montreal General Hospital. Look, there's a patient in with heart failure in room 306. Go see the patient and see if they have the signs and symptoms. And of course, you'd go in with your little book and say, yes, and come out after interviewing the patient, examining the patient, and say, yes, I think this patient does have heart failure. Well, that's not how patients present, especially in primary care. They present with vague symptoms, what many have referred to as undifferentiated illnesses: fatigue, headache, chest pain. The most difficult of all is, of course, abdominal pain, dizziness. These are the conditions that are the most challenging for physicians across the spectrum to evaluate. They're especially challenging in primary care because these patients present very early on. I see a patient with abdominal pain. I think they might have diverticulitis, let's say, but I'm not sure. I treat them, they don't get any better. And then I refer them to general surgery. And when they go to the general surgeon, they said, gosh, this is an obvious appendicitis. I need to take this appendix out. Why didn't Dr. Rao pick this up? Well, he didn't, because you're seeing the patient at a later stage. But across the spectrum, undifferentiated illness represents the bulk of a general practice caseload, not just diagnosis, everything. It's very relatively straightforward to manage chronic illness, which is a lot of what we do, and a lot of what specialists do as well. The diabetes checkup, a checkup for multiple sclerosis once the diagnosis has already been made, for example. But the undifferentiated illness is the biggest challenge in terms of our cognitive workload and also our time that we invest. The problem is compounded by the fact that guidance as to how to make a diagnosis is scarce, or it's of poor quality. And here's a glaring example of it. There's joint Canadian and American guidelines on dyspepsia, upper abdominal pain. How do you manage it? Patient comes in with upper abdominal pain. Well, I've thrown this question out to audiences of physicians, internists, family physicians, others, general surgeons, for example, generalists more broadly. And they all come out with very different answers. Some of them would say, well, depending on the patient's age, I'd give them a proton pump inhibitor for a few weeks and see if they get better. Some people say, I'll send them for endoscopy. Some people say, just have the patient take antacids and monitor their symptoms. There's no consistency whatsoever in how you approach the diagnostic dilemma that you're faced with. So, but within this guideline, prompt endoscopy is recommended for patients over 60 to identify malignancy, but the evidence supporting this recommendation is described as very low quality. If you look at this guideline, other aspects of management of dyspepsia are very high quality. How you do the endoscopy, how often you do it, what techniques you use for it, when do you do a biopsy, what to look for, how you treat peptic ulcer disease. That's all fine. But this particular thing, the prompt endoscopy, age 60. Why age 60? So if somebody's 59, you don't do it? The yield for malignancy goes down substantially at that point? There's no reason to support it. And this is what we're faced with, either guidance that's non-existent, which is the most common scenario, or guidance that is of very poor quality. Alan Detsky describes kind of a leading thinker in this area. Diagnostic excellence is requiring a comprehensive knowledge of diseases, skills, data gathering, competency in communication, judgment, integration, and problem solving. And this is probably the most important statement from this entire paragraph. Diagnosis is both an art and a science. Okay. Physicians, I will tell you, overwhelmingly focus on the art. I can kind of figure this out. I've asked a few questions. They get into cognitive conundrums like anchoring. Well, the first thing that matches my description or my feeling or my experience becomes the diagnosis. We had gone through a COVID epidemic, of course, recently, but there was an earlier one, so the original SARS, which was far less deadly across North America. But about 20 people died in the city of Toronto from SARS. This is back in the early 2000s. So it was rare, but I can tell you for a 3 or 4 week period, the number of potential diagnoses of SARS skyrocketed across the city. Everyone who had a cold had a potential SARS, right? So we can't trust our cognitive thinking as such. The artistic part of diagnosis is significant, but there has to be a scientific part as well. And that's what my center is devoted to. Now, diagnosis involves fast thinking via pattern recognition. So experienced dermatologists will make a diagnosis very quickly. or slower thinking through iterative analysis. So you need to have caring, curiosity, practice, experience, and feedback. You also have to acknowledge that you don't know sometimes. I don't, sure. I've run out of ideas. I'll have to think about it some more. Is there something you're concerned about? Or is there something more you think you could tell me that would help me make a diagnosis? That's hard for physicians and other clinicians to do with their patients, but I think it's extremely critical. So back in 2013, through some funding from the Agency for Healthcare Research and Quality, we developed a concept called the diagnostic path. And it's a very simple concept. It's just the sequence of steps that make up the diagnostic process from first presentation of a patient with a specific symptom until either diagnosis is made and treatment initiative, or the diagnostic evaluation ends for other reasons. As an example, consider you have a healthy young man, 35 years old, with abdominal pain. My diagnostic path might begin with obtaining a history and a physical, and he says he's had it for about 3 weeks. He has no nausea, no vomiting, no stool changes, nothing else, but just the abdominal pain. He's perfectly healthy. He's a non-smoker. Family history is non-contributory. Okay. Well, I'm still perplexed as to what might happen. So maybe I treat him empirically. And that would be step number 2, or maybe I send him for endoscopy. Or maybe I do some other sort of investigation, or maybe I do some laboratories. Maybe I do an amylase and a lipase looking for pancreatitis, or who knows what it is. But those are all steps in the process. At some point, I have to have a diagnosis, right? Medical care is all about making money. We must list something on that epic form that gives us the diagnosis, right? At some point, and we do that. And if that diagnosis becomes the basis for his treatment, then the diagnostic path is ended. Okay, we're not talking about whether the diagnosis is correct or not, but I've concluded my diagnostic portion. Now, there may be an error later on, but that's how we define a path. Now, how do we find out what best practices are using the concept of diagnostic paths? Well, first of all, you need problems for which there is no guidance or little guidance, which I gave you one example already in the abdominal pain spectrum. Secondly, the problem has to be common enough, right? So that enough physicians deal with it on a regular basis that we have multiple diagnostic paths to investigate as well. So together with some very technically gifted people, Rama Padman, Ying Zhou, both from Carnegie Mellon University, and my colleague Anthony Solomonides, whom some of you know, who is on the board of advisors for the UH Advanced Center, as well as others, Yi Zhang, who is now at Cornell, and my mentee, Dr. Curley, and Paul, who is the founder of the Society to Improve Diagnosis in Medicine. We wrote this paper, and the idea was quite simple. Patients with abdominal pain have a number of different underlying diagnoses. They also are managed quite differently with no consistency whatsoever. And I gave you the example, some people getting medicine, some people not, some people being sent home, etc. Can we look at all of those varying diagnostic paths and find out which ones are associated with the best outcomes, which I'll talk about in a moment? And these are what the diagnostic paths look like. Now, this is complicated. Sometimes you start here. This is one particular path. So somebody started here. This is the most common path in this particular slide. So they get an evaluation, which means clinical evaluation only. Then they are sent home, evaluated again, evaluated a third time, and a diagnosis is established. So many, many different ways to get to a diagnosis. So the outcomes that we are most interested in when we investigate best practices for diagnosis or diagnostic paths is accuracy, of course, is important. But also, people often overplay accuracy. Oh, I was misdiagnosed. Well, and I went to this other doctor and they got the correct diagnosis finally. Well, that's not exactly timely. If you went to the other doctor 3 months after you had abdominal pain, it's perhaps quite likely that the first physician or first clinician you saw wasn't able to make an accurate diagnosis. But the timeliness, waiting for 3 months, is quite some time. So timeliness is an important outcome. And resource use. If everybody gets a full body MRI, you will come up with some diagnosis, but that's not a good use of resources. So these three are always in balance when we talk about diagnostic paths. Now, how do we apply diagnostic paths through the UH Advanced Center? First of all, our goal is not necessarily identifying using diagnostic paths, but identifying best practices for important problems. So we select diagnostic problems which are common. They must be associated with high rates of diagnostic error and diagnostic variation. You can have a common problem like sore throat, but everybody's doing the same thing. If they're all doing a throat swab or a rapid strep, and everybody is, treating according to that particular paradigm, there's no variation there, right? And there's probably not a lot of diagnostic error. And also there has to be guidance that's lacking, because if there is guidance, even if it's not evidence-based, people will still follow it, and then that decreases your diagnostic variation, and they will challenge you on saying, no, this is what the American Cancer Society states, and so we're going to go with this. The second step after selecting problem is to identify outcomes associated with current practice or practice in response to pilot-tested interventions or recommendations, including timeliness, accuracy, morbidity and mortality, and use of diagnostic resources. So we do this through a review of evidence and data in our own health system. And then with clinicians and patients, we start the big process of developing and refining guidelines and tools for diagnostic evaluations. Then we implement those diagnostic guidelines within our own health system and monitor our impact. So it seems like a very obvious algorithm, but I can tell you that with the pilot problems we're at right now, we are still at levels 1 and 2. Our diagnostic center, Sam told you that we are one of 10. These are the others. And fortunately, it's interesting to me that there are 3 just in the Boston area. And I think there's 2 in Houston. So we're actually pretty uniquely positioned here. So we have, the East Coast and then the West Coast, 2 and 1 in Oregon and 1 in San Francisco, 2 in Texas, and then 3 in Boston, 2 in the DC area, rather, MedStar and Armstrong, which is near Johns Hopkins, not too far away. So we have a unique geography as far as our center goes. Also, a lot of these centers are focused on very, very different problems. For example, at Brigham, they're focused on radiology reports and increasing the accuracy of those, et cetera. So there's a very, very different, more focused approach in those. Identifying best practices for common but challenging undifferentiated problems is our unique sphere. Our mission, as Sam told you about, is to identify best practices for diagnostic evaluation of common conditions prone to diagnostic errors. The common problems we refer to are dizziness, undifferentiated abdominal pain, sepsis in children, hypertension in children, unintentional weight loss, which I'll talk about in a moment as well. The 4-step strategy that I described is the foundation for the center. We have an advisory committee and a diagnosticians panel. The advisory committee is actually the governance body for the center. It's not the research team. It's not me. So they will decide whether these practices are valid and should be implemented, et cetera. We want to be a focal point for improving diagnosis nationwide. We used to have weekly seminars. It's been difficult to get speakers for that. I'm going to urge all of you to think about it, and I have a request at the end of this talk as well, and workshops to begin late this fall. And we are a central component of the entire health services research effort, which Sam is leading. So we talked about the problem selection. The problem should be common. It has to be associated with both very benign and very serious underlying etiology. Let me give you an example. If someone has profuse hematemesis, vomiting of blood, I guarantee you that's a pretty serious underlying cause, right? Could be esophageal varices. I don't know. It could be a number of different things. But if it's always a serious problem, the problem is the diagnostic evaluation tends to go towards interventions and diagnostic tools that will pick up a number of different diagnoses. But if it's something different, like abdominal pain, which could just be indigestion, it could be pancreatic cancer. So the underlying problem you're approaching, if it's associated with very benign and very serious underlying etiology, becomes more challenging. If it's always benign, if it's sore throat is overwhelmingly due to an upper respiratory tract or viral or bacterial infection, that's also not a problem we would tackle. It has to be associated with significant variation in diagnostic practices. Usually the reason there's a variation is because best practices haven't been defined. And ideally, patients should be intrinsically involved in diagnostic decision-making. This is not about biopsying something and sending it to a lab and developing best practices for the biopsy or for the evaluation of the specimen. because the patient is not truly involved in that. When they can contribute important information to the diagnostic practice, it becomes more of a team-based effort. We have some demonstration projects, which I know some of you are already familiar with. We want to identify the best approach to evaluating unintentional weight loss in adults. This problem actually came to me through Jordan Winter, who is the head of our surgical oncology team here at UH. So he kind of turned me on to this problem as using weight loss as an early cancer detection tool, a very inexpensive tool. So Jordan and I and JJ Hugh, who's also the Department of Surgery, did a pilot study with my patients. And it was very simple. We wanted these folks, all of them are older people, to weigh themselves once a week and to text their weight to a central repository. And I was like, oh gosh, I don't know if they're going to do this or not. They did. 80% of them did exactly that. And they got $50 for it. And actually, I don't think that was a strong motivator for the 50 patients. I think some of them didn't collect that money either. So they actually did do it. And two wound up having, one had prostate cancer. And the other had more of a behavioral cause of unintentional weight loss. So we actually did quite well with it. But how do we approach it when the patient has unintentional weight loss? The general trend among my colleagues, and just based on anecdote, is that they kind of go crazy when I see an 80-year-old woman who hasn't been to the doctor for 6 months and has lost 10 kilos and says, I don't know why. Well, okay, are you depressed? No. Are your dentures, or do you have dental issues? No, I don't. Are you being neglected? No, I'm not. What do I think about? I think about malignancy, right? And then this poor lady is going to be subjected to colonoscopy, upper endoscopy, CT scans, etc. Maybe that's the right approach. We're not quite sure yet, but we have some preliminary information that will help guide us. Now, I'm very passionate about detecting high blood pressure in children. I've written extensively about it, was a PI of a study in Chicago about it. So I kind of rolled this into the center, partly through personal interest. And I see Dr. Ronas is on the call. She's also an investigator in this study. And the reason I became passionate about this is back in 2004, when I was in the Department of Pediatrics and I ran the pediatric obesity program at the University of Pittsburgh. They always sent medical students to come see us for research projects and QI projects. And I thought, oh gosh, and there's so many trainees all the time there. It was getting overwhelming. But this young man said, can you give me something to do? I said, why don't you look through some charts and electronic charts to see how many children have high blood pressure. And the population was mostly African-American there. And he did. He reviewed, I don't know, 50 charts. And there was one child whose blood pressure was systolic was 180 and diastolic was over 100. He was only 13 years old. He had obesity, and nobody made any note about this blood pressure in the chart. So we started with that. We started to put up those in 2004. The American Academy of Pediatrics published these standards and guidelines. We didn't get much traction out of it. And ultimately, through my work in Chicago, we discovered that measuring blood pressure in the office is a real pain. It's very difficult. To make a diagnosis, you have to have patients come back multiple times. So Sarah and I and others are engaged in a project to see if we can diagnose hypertension through home blood pressure monitoring. And that's underway now. The third project is being led jointly by Jessica Goldstein from the Department of Emergency Medicine and Charles Macias, who is with the emergency medicine division within the Department of Pediatrics as well. And it is looking at sepsis trigger tools and cohesive strategies to make a diagnosis of sepsis in community emergency departments and for children and adults in community emergency departments and inpatient settings as well. So it's a matter of implementing and refining tools over time. We have a panel which is led by Dr. Goldstein. It's interdisciplinary. These are not necessarily experts on the panel. What we will do is present our findings or some recommendation statements, and they will reach consensus through a Delphi method, which I won't get into in too much detail. But Dr. Goldstein is anticipating doing this probably this fall with our unintentional weight loss study as well. And of course, the research center will be evaluated. So Doctors Dolansky and Koopman Gonzalez are helping to lead our evaluation, which is essentially the efforts of implementation, including the reach of the center, et cetera, the infrastructure development, the four-step strategy, barriers and facilitators, the engagement of various members as well is an important part of it. So we have had some preliminary work that has been completed. The first was a paper that was published in Diagnosis last year. And it deals with recognition, diagnostic practices, and cancer outcomes among patients with unintentional weight loss in primary care. The bottom line from this is that we do a lousy job of recognizing unintentional weight loss in primary care, regardless of what you consider to be the criterion standard. So it could be 5% of your weight loss in 6 months or 10% a year. There's many different ones. No matter what definition you use, we do a terrible job of it. And perhaps it is due, so it has become a foundation for some of the work that we're doing. And this particular study got a significant amount of press as well. So we can talk a little bit about the findings as well. What we have found so far is that there is a wide variety of diagnostic practices for unintentional weight loss. In general, people are overdoing it, I think. I was overdoing it. I was ordering imaging and that sort of thing, and my colleagues are doing the same thing. It's very challenging to study because the vast majority of weight loss that you observe is intentional, and it requires a careful inquiry. No matter what the age, sex, gender, it doesn't matter. Whatever they have lost weight, it's almost always some intentional habits. In other words, it's planned. EHRs don't reflect a physician's thinking about it. So you find all these investigations being ordered for unintentional weight loss, but there's not necessarily anything in the chart that substantiates it. This is a controversial one, but I'll share it in advance, but doesn't look like endoscopy is useful unless they have relevant symptoms or signs, diarrhea, rectal bleeding, etc. Sort of a shoot in the dark endoscopy doesn't seem to be useful. Imaging is not useful. Laboratory tests are often abnormal. We're still debating PSA. There's a small number of patients within our sample who had PSAs that were positive. So if there is something that you want to do investigation-wise, the laboratory tests are relatively, of course, non-invasive, and PSA is one of those. That might be the way to go. But one of the recommendations we're going to make is that when you have a patient with unintentional weight loss, do a detailed inquiry into whether it was intentional or not, whether there are other causes that are non-cancer related, such as depression, neglect, social isolation, etc., which is very common in older patients who are more prone to this phenomenon to begin with. And also have them weigh themselves once a week. That's it. That's as simple as that. But more to come on that later this summer and this fall. We have also formed a partnership with the Ida Hospital in Taiwan. So one of the requirements of our center is to form meaningful partnerships with other organizations. Those organizations can't be other centers because we were already collaborating. So, you can't cheat and say, oh, no, I'm on the Johns Hopkins advisory board and someone from there is on our board. That doesn't count. You have to have some legitimate collaboration. Department of Family Medicine has had projects in Taiwan for a long time. The Ida Healthcare Group is helping us to develop an AI-based tool for unintentional weight loss. So the role for AI is illustrated here. We think that clinical decision support and guidelines might be useful. I just gave you some prospective guidelines. I said, patient who comes in, don't order endoscopy, don't order imaging. You can order some lab tests if you have a reasonable suspicion. This is someone who has no symptoms or signs suggestive of one cause or the other, and help them monitor themselves weekly. If we implement that guideline, we're still going to miss something, right? So can AI play a role? So this might be the scenario. We look at a 73-year-old woman who has only a history of well-controlled hypertension, comes to your office for an annual checkup. She feels well, has lost 16 pounds unintentionally since you saw her 6 months ago. she wasn't overweight to begin with. What sort of diagnostic evaluation would you recommend? And what is the likelihood she has an underlying malignancy? Let's say that's my patient. I would put in some of these details or look at from the chart and put it into AI. And the difference is that the AI program that we're developing in collaboration with the institution in Taiwan will look at subtle signs and features. Maybe the frequency of her checkup visits has gone down or it's gone up. You know, maybe there's something else in the chart. Maybe some laboratory test has changed in subtle ways that suggests that she may have an underlying malignancy. So that's the level of guidance we're looking at. We're not looking at AI to replace the general broad guidelines, but looking at this patient, what is her likelihood that she has an underlying malignancy on an individual level is how we believe AI can help us. Now, we are planning to submit a proposal in this area looking at maybe January or February 2025. Now, my final thing I wanted to tell all of you is you have the opportunity to join the UH Advanced Center as an affiliate member. We have a number of affiliate members, and this will include contributing to future projects, being a recipient of our newsletter, and receiving some guidance or mentorship as well in the diagnostic field if this is something you're interested in. So if you have any of these interests, I really urge you to send an email to Evelina, who is the research manager for the UH Advanced Center, and she will be very prompt in responding to you. I guarantee that. So thank you very much. I'm going to move on to our last slide, which is questions.
Thank you, Gautam. This was great to have an overview of the UH Advanced Center, and it seems like a lot of wonderful work is going on. We do have many participants from outside of the UH system, from different parts of Northeast Ohio, including our partner institution, NeoMed. So I think it'll be great if we can have more affiliate members in your center. So we have time for a few questions. Just to remind everyone, you can type your questions in the chat, sorry, in the Q&A section. And if you want to submit your questions anonymously, you can do that as well. So while we're waiting for questions, I guess my first question, I'll just start with it. So the UH Advanced Center, it seems like it's a grant funded, it's R18 ARC. So what's the sustainability plan of this? What happens once the grant is over?
Yeah, that's a great question. So we're now in the second year, Sam, of a 4-year grant. The diagnostic centers of excellence are all meeting together this fall in Washington, D.C. to discuss sustainability. So sustainability is very, very important. And there's many different ways to do it. One is to apply for new funding, which we will do with the Taiwanese colleagues that I described, for example. The second thing is to operationalize some of the successes that we had. So, for example, Drs. Goldstein and Macias, their trigger tools will be incorporated system-wide. Our protocol for home blood pressure monitoring and our clinical decision support around unintentional weight loss will be sustained as well. The most important thing we want to do is to become a repository, a collaborating site for approaching new problems. So these are problems our team is very interested in, but they may not be the same things that other health systems are interested in, and they may have different needs altogether. So let's say you have a healthcare system in Los Angeles that, for example, that has an interest in something completely different. Maybe it's pediatric abdominal pain. Okay. Well, we don't necessarily have the leading expertise in it, but we'll say, let's look at that 4-step algorithm. You've identified this as a problem. Let's look at the evidence for the best approach. Let's look at our large repository of data and look at how people are managing the problem now. And let's give you some guidelines. Let's put it through our diagnosticians panel and our board of advisors. And here's a nice set of recommendations that you can take and turn into clinical decision support, or we can help you to do that. So it's almost like a contractual mechanism with other centers that have an area. But the big goal, I think, is to create a large community. And that's why I implore people to join who have an interest. Because once you do that, people say, hey, I have a great idea. And we can say, okay, let's think about that idea carefully. And what do you want to do with it? Do you want to do you want to write a paper? Do you want to submit a grant proposal, or do you just want to explore the idea with our team? So that's another form of sustainability as well.
Thanks, Gautam. A related question, I guess. What is the process? Is there a cost involved, or what happens when we put forward, let's say I want to put something related to my field of interest, and which the center may not have in-house expertise. How is the process? How does it work in terms of what's expected apart from just putting forward the request? Is there a cost involved? What's the timeline? And what are other
Yeah, so those are things we have yet to work out. So we are proposing this mechanism to identify best practices to ARC this fall. October 24th and 25th is the meeting. So we'll go there and say, hey, this is one of the things we want to do for in terms of sustainability. Now, if it is a matter of a consultation, is probably what we would go into that, and it would be a very low cost to begin with. So, if you have a particular problem, we say, well, this is not approach. We can't handle this problem. It's not possible to develop best practices. That might be one of the outcomes, and we wouldn't proceed further. Or there are already best practices, in which case we wouldn't proceed further. But the cost, when you think about it, Sam, I think there is a cost for meeting the diagnosticians panel, the advisors, the data extraction and analysis. We pay for all of that now through the UH Advanced Center, so it would be comparable in cost as well.
I think we have a question from
Yeah,
Karen.
we have one. Hi, Karen. Thank you. She said, this is great and fascinating. As you probably know, a lot of specialty groups have their own guidelines, the ASAP clinical practice guidelines or GRACE. How do you see this work fitting into it? Yeah, it's a great question. And some diagnostic guidelines for specific types of problems are very well done. There's no question about it. But the vast majority are not. They're consensus driven. So meaning that a group of people, and some of you may have been on guideline committees, sit around and say, hey, I think this is what we ought to do. Migraine headache, well, let's get a CT scan if it goes on for more than 4 weeks and there's more than 2 episodes a week. Where did that come from? That's not our approach at all. Our approach is data driven, looking at what people are doing now and who has the best outcomes and what's the most the most cost efficient and timely way to approach it. So I think that societies we hope to partner with as well going forward at some point, or at least to have some representation in terms of our approach. We have a data-driven approach. We're not experts in pediatric abdominal pain or Parkinson's disease or anything like that, but we have a data-driven approach that may help you or help inform the guidelines that you have developed or planning to develop.
So I have another related question. So when you showed the 10 centers, so the 10 sites, clearly we see some differences, geographic differences. So 2 questions. First is, just as you mentioned, like Brigham and Women's, they have a focus on radiology. So do we have at UH an area of focus for the center? And the second question is, why do you think we have these geographical differences such that we end up with 3 sites in Boston and just 1 site in Midwest, if I'm remembering it correctly?
Yeah, that we're the only site in the Midwest. So first of all, we have diagnostic initiatives both in pathology and radiology here, which I don't lead, that are outside of the UH Advanced Center and that are very, very robust. Our focus, was driven, I think, largely by ambulatory care, largely by primary care, and that's been my emphasis for a long, long time. So, and I think we are unique in the sense that it seems very broad. I want to develop the best diagnostic approach to some undifferentiated problem. To people who are much more specialized or focused on laboratory medicine or something of that seems like way outside their realm, because, well, isn't that an obvious sort of thing? It's not obvious, right? You think it's obvious, but we don't have best approaches. So that was what stimulated my interest. So that's driving it. The geographic variation is interesting. And it's the age-old phenomenon, the rich get richer, right? So I remember at Stanford, for example, when they submit their K awards, they ask department chairs, I want you to identify 2 to 3 people in your department who might be potential K Award candidates. And they send a mentor out there for that person, help them develop their application. When you review those applications, they're absolutely perfect. They're completely perfect. And then you say, well, you've got somebody in Toledo or in Lansing or Hershey, Pennsylvania. They don't have those resources. And so they tend to pool things. The Boston group, 3 centers just in Boston, just within the Harvard system seems like a lot, but it's a community that's relatively small. And again, their applications are outstanding. So the ARC didn't have much choice in that matter, but it would be nice to have more diversity for sure. Looks like another question, Sam, in the chat. This is from Kieran again. There's always the medical legal concerns with guidelines. If a product doesn't enough, how vulnerable are they to litigation? That's interesting. Guidelines are meant to be just that. They are not prescriptive in the sense that this is what you must do. So if you are brought before a legal committee or in a court, you can always say, well, this is why I felt I ought to deviate from the guideline. If you look at the actual recommendations, they are quite subtle sometimes as far as that goes. In fact, I think that we're choosing things, Kieran, I think, that don't have guidance for the most part, or the guidance is admittedly poor. I gave you the example of dyspepsia, the age 60 cutoff. Well, they admit there's very poor evidence for that. So if I inform that particular recommendation with data and say, oh, no, 60 is not a good cutoff, you need to go to 50, or maybe you need to go to 70, I'm actually protecting myself even more. So we're not trying to displace guidelines that are established or ask physicians to deviate from them. We want to provide them with information where there isn't any.
So Gautam, do you mind again putting that slide to contact your research team? I think be helpful. And so my final question is more related to junior faculty. And again, are there any specific mechanisms for junior faculty to be involved with your center, more from developing, grantsmanship or some other skills, along with the diagnostic excellence? So more from, I guess, just like, the Stanford example you gave, how you develop this R18, could we train our junior faculty so that in a few years down the line, they could think of
So there's a number of different mechanisms. The one I recommend the most is the SIDM Fellowship, the Society to Improve Diagnosis in Medicine Fellowship Program. And so Kelsey, I think, is on the call. Kelsey is a graduate. Kelsey, if you're on, do you want to give us just a couple of words about the process of applying? You're more familiar than I
am. Of applying for a grant at AHRQ?
No, for the SIDM Fellowship.
Okay.
I know it's been a while, so.
Okay. Well, to begin with, you need a diagnostic project that you can do, and the SIDM Fellowship usually lasts about 1 year, so it's helpful to have a project that you can either finish or make very significant progress in that time period. So, you put together a project plan, and of course, it will change over time. And that's very much like it is when you apply for any sort of grant, although it doesn't have to be quite as developed. Once you become a fellow, there'll be regular meetings over the course of a year, and they'll match you with a mentor who has similar background to you, so that you can talk about how the project is going along, and as well as ask things such as career development or how to what a good follow-up project may be, that sort of thing. Did you have any other questions about it?
No, I think that's great, Kelsey. So I would say if someone's interested in the fellowship, reach out to Kelsey. And I personally, I will mentor anyone who is accepted to the fellowship. But as Kelsey said, they select the mentor for you, but I'm willing to help as much as I can. We have a question from an attendee. Have you run into troubles accurately diagnosing patients based on differences in a manifestation of symptoms between men and women? If so, how does this affect the diagnostic approach? Yes, the answer is yes. Abdominal pain is the prototypical example. So when we looked at, there's a few papers that you could look at on diagnostic paths for abdominal pain. Obviously, very different diagnoses being considered in women, with many pelvic sources of abdominal pain as well. I will also say that, this is an early finding, but the prototypical patient with unintentional weight loss is a woman, an older woman. And I don't know why. That is, it may just be that women are much, much more engaged in healthcare, and therefore there are more weights to actually pick up. That's my suspicion as well. But that's the prototypical patient. But beyond that, we don't have a lot of data, but we do expect that that patients will vary in their diagnostic approach depending upon their age, number one, and their genders. Those are the two biggest factors.
Thanks, Gautam. If we don't have any other questions from the audience, then I think this brings us to the end of this session. Thank you so much for being our inaugural Grand Round speaker. And I urge everyone, the audience, to share this information within your professional networks and institutions, to join the UH Advanced Center as an affiliate member. This was a terrific session, and so I'd like to acknowledge the support of my team, Nicole Bollinger, Abigail Zona, Lisa Hackle, and E. Fritz, who helped us run this series so seamlessly. So tune in for more Grand Rounds presentation. We have it third Tuesday of each month, all the way until May 2025. We have very exciting lineup of speakers from university hospitals, as well as from other institutions regionally and nationally. Also, watch out for the emails for the Distinguished Speaker Series, which is on the first Tuesday of each month, with leading international and national speakers. Thanks, Gautam, for your time. This was fantastic. We really enjoyed having you here. Kelsey, thank you for chiming in as well. This is great. Thank you, and have a great day, everyone.
Thanks, everyone. Have a great day. Bye-bye.